But I thought I would begin just by giving you an idea of the scope of traumatic brain injury in our country. So within the United States, there's an estimated 2.5 million TBI emergency department visits, hospitalizations, and deaths, according to the CDC. And we recognize that approximately 3/4 of these are going to be of the mild nature of traumatic brain injury. And so historically, we've had this, this type of breakdown of classification of traumatic brain injury. This may change over time because especially between mild and moderate, this doesn't give us a great deal of prediction in regards to outcome, but this is how it's been done for a while now. And today we're going to be focusing on mild traumatic brain injury. So in the clinic, that's defined by a Glasgow Coma score in the range of 13 to 15 within 24 hours of injury. If there is amnesia, it's going to be less than 1 day of occurring. That can be anterograde or retrograde. And then if there is loss of consciousness, it cannot be longer than 30 minutes to meet this classification. And so just for perspective, you can see the more moderate and severe versions. It's not as relevant to what I'll be presenting today, but just gives you an idea of the spectrum of traumatic brain injury and how it's classified. So some of the symptoms of concussion or mild traumatic brain injury, these terms are commonly used interchangeably. Headache, nausea, dizziness, light sensitivity and blurred vision, ringing in the ears, and slurred speech. So oftentimes these patients will present with a delirium-like state. And they may or may not show overt signs of injury, because sometimes this can be, a bump on the head, a fall off of a ladder. But hopefully someone can give you an idea of the history of the injury to give you a bit of perspective why they might be presenting with these symptoms. So preclinical or rodent studies, primarily rodents, some primate studies, have given us a fair amount of insight in regards to what happens during brain injury. So this really includes the more moderate and severe as well, although many of these features are going to be shared by a mild traumatic brain injury. So shortly after the time of injury, there may be necrosis. So depending on the type of injury, we can have, even with non-penetrating injuries, we can have things like axonal shearing. This is quite common, especially at the borders of white matter and gray matter, where the axons are literally shearing. We can have other types of structural damage that are also sufficient to induce necrosis. So shortly after this, we see evidence of axonal injury. That evidence actually takes a little bit longer to show up, followed by evidence of glial damage. And then also apoptosis, so some cells may be damaged to the point where there's essentially no real cellular recovery, but it wasn't to the extent to induce necrosis. So apoptotic pathways may be recruited, and we can see evidence of this within a few days after that initial injury. Also demyelination, and the time frame that we are really interested in is this weeks to months, because we're really interested in some of the long-lasting effects of mild traumatic brain injury. And we see some of the processes that are really recruited during this time are microgliosis, so activation of those resident monocytes within the brain. And then there's also chronic inflammatory responses. So the innate immune system can be engaged for a very long time after the initial injury. So some of these effects of the innate immune response are thought to be beneficial, but some of these effects, especially the ones that are more prolonged, are actually thought to be detrimental. So I'm going to take a step back and tell you how we got started in this, because when I went through my graduate training and postdoctoral training, all of my interest was really in drugs of abuse and addiction, and using behavioral and genetic models in order to best understand what happens to the brain to promote long-term craving and relapse. And so shortly after getting to the medical college in 2012, I met Brian Stemper, he was in the Department of Neurosurgery. He's now part of the Department of Biomedical Engineering, as well as Matt Buddy in the Department of Neurosurgery. And I was exposed to some of their work. So Brian Stemper is an engineer, and he developed a blast model of mild traumatic brain injury. Originally, this was developed to mimic the blast exposures that so many combat veterans are exposed to. So we know that many combat veterans are surviving injuries that in the past would have been fatal. And we know in current warfare that these troops are engaged in, there's a large number of IUDs, or improvised explosive devices, IEDs, excuse me, not IUDs, but they're exposed to a lot of IEDs, and many of them are now wearing jackets that can protect them from shrapnel or the devastating effects of blast on the lungs. So the lungs are among the most susceptible areas of the body to blast exposure. But many of these soldiers are coming back with evidence of mild traumatic brain injuries, and so Brian's lab developed this blast model to try to mimic blast exposures in the theater of war. And so in this model, this is done using rats, and the rats are anesthetized with isoflurane, and then they're put downstream of this shock tube. So this is about 3 meters long. The first meter is a pressurized section that is filled with helium. There's a mylar membrane here that ruptures, and then this driven section guides a blast wave out of the end, and there's gases that come out straight. The animals are not exposed to that physical air, but there's a shock wave that expands at the end of this shock tube. And being engineers, they of course have pressure transducers and high-speed videography where they can really well characterize this blast exposure. So in the model that we'll be looking at today, the animals are exposed to a peak overpressure of 450 kilopascals, but you can see the waveform here where that peak overpressure is actually extremely short. It's on the time course of microseconds, and then the rest of the waveform is complete within about half a millisecond. And so this really does mimic many of the parameters of an explosion in an open field that these soldiers are being exposed to. And in their data, in collaboration with Matt Buddy's lab, well, they've looked and seen no gross evidence of any hemorrhage or anything like this consistent with a mild injury. They've done structural MRI, so in the T2 weighted images, they don't see any evidence of microhemorrhage or anything like that. But what you're looking at in the color coding is a study using diffusion tensor imaging. So specifically, these are fractional anisotropy values, and you're looking at the p-values of comparisons between animals exposed to this blast or sham-treated animals that went through all of the same exposures, but they were in the same room in an area where they were not exposed to a significant blast overpressure. So in the yellow, you see the highest p-values, and what's really noticeable is that even though the animals, their heads are facing this way, so they're essentially being blasted from one side, we still see bilateral damage, especially at 30 days post-injury. But what was really interesting to us is this area in the medial aspect, very rostral or anterior in the rat brain. So this represents the medial prefrontal cortex. So obviously there's damage in other areas of the brain, but also notably, we have an increase in the extent of changes in that FA value between days 4 and days 30 following injuries, suggesting that secondary injury processes are taking place, and these could contribute to very long-lasting changes in the animal's neurological function and behavior. So our collaborators had also demonstrated that anxiety-like behaviors are elevated at day 30 following injury as well, giving us some indication that there are some chronic behavioral deficits in the rat. So it's a little difficult to translate time course between the rat and the human, but just to give you a little bit of perspective, a typical rat lives between 2 and 3 years. So 30 days is quite a long period of time in these animals. So Brian and Matt's labs had also demonstrated within the medial prefrontal cortex evidence of long-lasting astrogliosis. So this is glial fibrillary acidic protein, or GFAP, levels in the medial prefrontal cortex 30 days following injury. Just a qualitative study, but showing signs of astrogliosis that endure this long after that original injury process. Now again, focusing on the prefrontal cortex, we also know that the prefrontal cortex is vulnerable to both blast and non-blast mild traumatic brain injury in human. This has been shown quite consistently. And we can use the rodent as a nice model for many of the behaviors that we're looking at, because there's quite a bit of homology between the human and the rodent medial prefrontal cortex. So here we're seeing a mid-sagittal view of the human brain and a coronal section of the rodent brain, so you have to reorient yourself a little bit. But the color coding shows the orthologs between the human. So here we see the anterior cingulate cortex represented here in the rodent. We also see this more dorsal aspect, area 32 of anterior cingulate, that's represented by what's called the prelimbic prefrontal cortex in the rodent. And then this infralimbic area that's really part of the ventromedial prefrontal cortex in both of the species, represented here. Now the rodent prefrontal cortex also serves a lot of the same functions as the human dorsolateral prefrontal cortex. So things like executive function, decision making, and these things are all subserved by the rodent medial prefrontal cortex. So as a reminder, this is an area that was really extensively changed following a single instance of one of these blast exposures. So to get into some of the significance of the work we'll be presenting, in patients, cognitive and executive dysfunction is among the most common enduring complaints following mild traumatic brain injury. And so the estimates of prevalence are really varied. Estimates are anywhere between 30 and 50% of patients that have problems with cognitive function or executive function greater than 3 months following injury. There's some evidence that these higher incidences are associated with studies that are done in the clinic as opposed to just self-report, and studies done using neuropsychologists in order to do the screening. So with more rigorous testing, it seems like the prevalence rates may be a bit higher, because not everybody is necessarily taxing their brain to the same extent and recalling the same experience in self-reports. So we also know that executive dysfunction is a risk factor in addiction, and we also know that unfortunately a lot of the preclinical studies have focused on spatial learning following traumatic brain injuries. So many of the older methods of inducing traumatic brain injury, even if they are considered quote-unquote mild, involve a craniotomy and, for example, a cortical impact onto the parietal cortex. And in the rodent, the hippocampus, the dorsal aspect of the hippocampus, is just below this cortex. So it's a bit of a different anatomy than the human condition. And in humans, spatial learning deficits really are not reported to a great extent in mild traumatic brain injury. So although people have found positive results and found positive findings in regards to treatment strategies for this type of behavior, it's really not particularly relevant to the clinic in regards to mild traumatic brain injury. So I won't spend too much time on this, but one of the first things we did was a series of cognitive tests that we felt would be more representative of the human condition, and especially cognitive tasks that would really tax the ability of the animals in regards to using their cognitive function, and especially these prefrontal regions. And so we did one task called operant set shifting. This is actually the rodent analog of the Wisconsin card sorting task, where the animals actually have to learn one type of rule and then ignore that rule and take on a new rule. I'll go into this task a little bit more to explain it better, but it involves a phenomenon called set shifting, where you have to use a different type of rule in order to successfully perform the task. And then we also did another type of cognitive flexibility task involving reversal learning. So then once we have them learn a new task, we have them reverse the rule of that task as well as another type of cognitive flexibility task that has a little bit different of a dependence in between medial prefrontal cortex being more involved in this set shifting and orbitofrontal cortex involved in reversal learning. So what I didn't point out is that in a rodent model, the orbitofrontal cortex does not undergo extensive damage. It's actually more lateralized than the orbitofrontal cortex of the human. And then we had them do a working memory task called operant delayed matching to sample. And this is also known to be medial prefrontal cortex dependent in the rodent. And so the animals went through this pre-training phase where we simply trained them to press a lever to get food. We make them hungry. They're at about 90% of their free feeding weight, so they're pretty inclined to do this. It's a very simple task to perform. There's two different levers, so we train them to do each lever, but there's no rule associated with it. So if a lever sticks out, press it, get food. Then the animals go through a series of training. So first this visual cue discrimination, then this set shift test, and then a reversal test. And then finally we tested their working memory. And to give you an idea of the time frame, just based on parameters of doing the injury at the VA, transporting, and then all of the other training that takes place, all of these tasks were done at 5 weeks post-injury, so pretty close to the time frame that the neuroimaging study was done. And then this working memory task also takes quite a bit of extra training. So results from this are going to be largely dependent on weeks 6 to 11 after injury. So in this visual cue learning, it does involve a rule, but it's another quite simple task. So the animals presented with two levers, or actually before they're presented with two levers, one of two lights comes on. The light stays on, and then the two levers emerge, and the animal simply has to push the lever under the light. So they don't have to remember anything. They just simply have to learn that wherever the light is, you go there, push the lever, and you will get food. And we do about 150 trials a day. And we have quite stringent criteria where the animals have to successfully perform the task 10 consecutive trials in a row to meet the criterion. And we were actually not expecting to see any difference here, but what we did find is that the animals really showed a very wide range of responses in acquisition of this task. So we're using box and whiskers plots because this data is very heterogeneous. So with the range, we actually found that one of our blast-exposed animals met criteria the fastest, but on the contrary, it took one of them about 220 errors to meet this criterion. And then you can see the median here and the quartiles here. So really, about half of our animals are within the range of the sham-treated animals, but some of them are quite a bit worse, but importantly, all of the animals did meet that acquisition criteria, which again is quite stringent. So they weren't completely impaired in learning, but the acquisition was delayed. When we tested them 24 hours later in 20 trials, looked at the number of errors, there was a trend for a difference, but it didn't meet the 0.05 level of significance. So this is where we really thought we would find a difference. It's a more flexible, now all of these tasks do require some flexibility, but this is one that requires that set shift that we know is medial prefrontal cortex dependent. But surprisingly, we didn't find any difference in the number of errors to criteria in this task or performance 24 hours later. So what the animals had to do is, this is the task I just showed you that the animals originally learned on. They had to, now the trials look exactly the same, just like in a Wisconsin card sorting task, but now we changed the rule to where the left lever is always correct. So they have to ignore the light, ignore the old rule, and shift over to a different type of rule that is based on the location of the lever. And we were surprised, really, because this is a difficult task. We were surprised to see that there wasn't any significant difference. And then we did a reversal of this task, meaning that now ignore the left lever and the right lever is always correct. So there's two competing rules, and now they had to do this shift over to the right side being correct. And again, we didn't see any significant differences in this task. So the animals next went on to a working memory task called delayed matching to sample. So the animals are in the same type of chamber, and one of the two levers comes out. The animal pushes it because they remember that pressing levers usually gives them food. And then there's a delay phase. This can last anywhere between 0 seconds and 24 seconds. During this delay period, the animal has to put its nose into this food bin to get food. The delay is not signaled, so the animal has to just keep poking its nose, and then when the delay period is over, the first nose poke response will then trigger extension of the two levers. So the animal has to remember which lever was sampled within this trial and match to it during this choice phase where both levers are available. So we do 140 of these trials per day, so there's a lot of potentially interfering memories associated with this, but in the end the animal has to just remember what side the sample phase was on across a series of delays. So if they do it correctly, they get food, and if they don't get food, but also we give them a visual signal and then an additional timeout period, so they have to wait longer until they're able to earn food again. So we were again pretty surprised to not see a difference here. So these are the different delay periods tested and the proportion of correct. So you can see with a very short delay period, the animals reach about 96% correct responses, and we see the expected degradation as these delay periods get longer, but we didn't see any difference in this task, nor did we see a difference in the time that it took to train the animals on this task. So in summary, we only saw a difference in this visual cue discrimination. So really our measure of executive dysfunction was, we did not see executive dysfunction, at least in this task at this time frame. So it may be that there's other regions that are driving this difference and not showing a difference here. So one of the ones that we have our eyes on is the anterior insular cortex, which is shown here. And there's also the medial dorsal thalamus of the rat is here. This provides a major glutamatergic projection to the medial prefrontal cortex as well. So it could be that these interaction of these effects could be driving this to a greater extent of affecting this. Now it could also, now these tasks were done quite within a few days of each other, but especially in regards to the working memory task, this could be related to the time of injury, so we really need to replicate this at a time point more consistent to where we know that there are changes in the brain. And also another concern with this design is that the cognitive training that occurred here before this task could have potentially increased performance on this other task. So there are a lot of caveats to this work, but we had a limited number of animals and a limited amount of time to do this, so we did push them through a large battery of tests. Now I want to shift gears and move over to substance abuse, because this is also, like executive dysfunction and cognitive problems, it's also a substantial problem with mild traumatic brain injury. Although the way that many of these clinical studies are designed, it's a little bit difficult to really determine, whether it's a chicken or an egg phenomenon. But regardless, there is evidence of increased rates of substance abuse in traumatic brain injury patients. In this study, TBI sufferers without a substance use disorder in the year prior to injury had an odds ratio of 4.5 of developing a substance use disorder within a year of injury compared to those without TBI. And in another study, 18% of brain injury patients with no history of substance use disorder were diagnosed with one following injury. And so really there has not been a clear consensus on whether the neurological effects of traumatic brain injury contribute to substance use disorder. We know that people who abuse substances are more likely to have brain injury. We don't necessarily know their prior history. You know, substance use disorder actually depends on proper diagnosis by a clinician. So many people meet these criteria but are not actually diagnosed. And so this makes it really difficult to fully interpret clinical data. But more recently, a series of groups have been investigating addiction liability in preclinical or rodent and primate models of traumatic brain injury. So some of the first work was done with showing increased alcohol drinking and self-administration. So actually we should be on this list too, kind of in the middle of these. But a number of studies have found elevated levels of alcohol drinking following traumatic brain injury. And a couple of studies have found elevated cocaine conditioned place preference. So this is one way of assessing cocaine-related reward. But the model that we prefer is one where we have the animals actually giving themselves the drug of abuse. So we do intravenous drug self-administration. So for this study we do rats. For other studies we also do mice in our lab, but we do jugular catheters that are chronic, and we have a terminus of the catheter that extends out of the back, so we can connect and disconnect them on a daily basis to these chambers where we can teach the animals that if they perform a response on one lever, then they get an intravenous infusion of a drug of abuse. If they hit the other lever, then nothing happens. And so when we do these types of experiments, this is just stylized data illustrating response rates on the active lever, the one that delivers the drug of abuse, versus the inactive lever that has no consequence. Animals will learn to discriminate these two levers during the self-administration phase. And then we can do what's called extinction, where we replace the drug of abuse with just saline infusions. And so originally the animals are just hammering on the levers trying to get their drug. So I really need to redraw this because it's typically up here. It's really exaggerated, but you know, rats and mice are not unintelligent animals, so they will learn that over time that this drug is not being given to them any longer, and so you'll see this extinction curve. And then we can do tasks of reinstatement, where the same types of stimuli that induce craving and relapse in humans will also increase responding under these same extinction conditions. So the animals are still receiving saline infusions, but we know that stress, environmental cues, or a little bit of the drug itself will elevate active lever responding. And importantly, we know that the same areas of the brain, including the medial prefrontal cortex, are engaged in the rodent brain, as human studies have shown using functional MRI are engaged by either stress or drug-associated stimuli. And so we can use these phases of this type of experiment to examine vulnerability or drug sensitivity. For example, we know that by giving animals chronic stress, we can actually provide a leftward shift in this curve, and animals will actually learn to self-administer a dose of, for example, cocaine that's not self-administered by other animals, so it basically pushes a particular dose above threshold. We can use extinction to look at persistence of drug seeking. So similarly, stress will actually extend this curve, or things like environmental enrichment, so cognitive enrichment, exercise, social engagement, will actually facilitate this extinction response. And then we use this as a model of craving and relapse. So this is what it looks like in the rat. So this is one of our rats doing self-administration. In this case, this is oxycodone being delivered. Each infusion is going to be 1.1 milligram per kilogram per infusion, delivered over about 2 seconds in 40 microliters of solution. So it's a very fast onset. So you can see when the animal first gets in the cage and has maybe a couple of infusions, actually gets quite excited. They actually get excited when you go to the housing colony and go to get them. But then, of course, being a pretty profound sedative, the animal undergoes pretty profound sedation over time. And this is a little area where there's no food here, but it can be used as a food hopper. The animals tend to use it as an armrest while they are sitting back and self-administering oxycodone. So, is this a significant thing to understand? Well, I hope you understand that the answer is yes, but I'll give you a little bit of information that might support that. Well, unfortunately, there's no standard treatment for mild traumatic brain injury. It's really going to be based on symptoms, and oftentimes patients are sent home, and if you have a headache, take an over-the-counter pain reliever, or call me if you have any other problems, but otherwise, rest. We also know that substance use following traumatic brain injury is associated with worse psychiatric outcomes, so we don't want this to happen if we can avoid it. And in regards to opioids, although opioids are certainly not a first-line therapy for mild traumatic brain injury, it turns out a lot of people that experience mild traumatic brain injury get opioids. So in the only study I've been able to find of general trauma patients with mild traumatic brain injury, over 90% of them received opioids within 24 hours. In a study of adolescent sports participants, 20 to 30% received a prescription opioid, and with an additional 6 to 10% of them using them illicitly. And then in regards to military personnel, so in military personnel that suffered traumatic brain injury, 40% were later reported to be opioid users, whereas 55% of them were misusing prescription opioids. And then in the larger scope of things, we saw in 2016 32,445 deaths just involving prescription opioids. That doesn't include heroin. In the United States in 2016, we can see kind of the overall trend shown here. This is now looking at anti-opioid, where it's a little over 13 deaths per 100,000 in the population within our country. Of course, it's also a problem within Milwaukee. So this is over the course of a few years, just showing the sites of this does not include overdoses that involved successful use of Narcan, but these are overdose deaths in Milwaukee, and you can see really it's a widespread problem. It's not just isolated to particular communities. And so finally, in this next experiment, we're using repeated injuries. And again, this is something that's quite significant to the TBI population. We know that in humans, there's a relative risk of getting a second TBI is up to threefold greater than having a single injury. And then upon having two injuries, the risk of a third is approaching ninefold greater. So many people who experience traumatic brain injuries are going to have more than one. And this is also associated with longer symptom duration, so it's significant to study. So what we did using that self-administration model with oxycodone is expose the animals to 3 blasts over the course of 3 days. The animals are handled, and then they undergo the jugular catheterization surgery. They're trained to press levers in order to get food. They're not hungry at this point, but they still like sugar pellets, so we train them to do that, to make sure that all of the animals have learned this type of task before we give them access to oxycodone for 2 hours a day. First we make them press the lever twice to get it, then we make them press the lever 4 times for each infusion, and then we do an oxycodone seeking test where we have 10 days of extinction. And I'll show you a small data set where we actually look at reacquisition of oxycodone self-administration. So after this abstinence period if we give them oxycodone again. We have some data from that. So the repeated injury really doesn't seem to have any gross effects that are any greater than a single blast. So our experimenters are blind to the experimental condition, and if I ask them to guess who is who, they really have no idea. We also grade this in a composite neuroscore. It's just things, really gross neurological function, looking at if we push the animal from the left or from the right, do they fall over? Can they balance on an incline or decline plane? Things like that. So no difference there. They can acquire the food self-administration, so this is showing active versus inactive responding in both groups, and the proportion of their responses on the correct lever. And then in this particular study, this is what the acquisition curve looks like the first 4 days, and then when we have them press 2 times to get a single piece of food, all of the animals are perfectly capable of doubling their responses in order to earn the maximum number of food pellets that we will let them have. So then when we move on to oxycodone self-administration, we didn't necessarily hypothesize there would be differences here. The medial prefrontal cortex has been shown to have some involvement in regulation of drug intake, but it's not really considered to be a core part of the brain circuitry involved in the reinforcing effects of drugs of abuse. Now, if anything, we saw a trend for lower active lever responding in the repeated blast traumatic brain injury animals, so that's what RBTBI stands for. So this is across having them press twice and then 4 times to get each infusion. So the animals will modulate responding to do that. If we look at these same sessions in terms of the number of infusions earned and corresponding amounts of total oxycodone, you can see that if, again, there's actually a significant depression in the number of infusions earned in the blast animals, but when we had them press 4 times, we lost that effect. So if anything, these animals are taking less drug under these conditions with this dose of drug. But then if we put them under extinction conditions, despite that lower history of intake, they actually have significantly elevated responding when we replace it with saline, so this drug-seeking behavior. So there's a main effect that occurs across all 10 days, and this effect is most significant at this first extinction session. Now, if we go back and think about the animal's drug history, we can actually see that in sham-treated animals, the total amount of oxycodone taken during those 10 days of drug self-administration nicely associates with day 1 active lever responding under extinction conditions. So what that means is that these animals that took more drug when they were allowed to take drug had a higher amount of responding in that seeking phase when they were self-administering saline. This isn't necessarily surprising, but what we saw with our repeated blast-treated animals is actually a loss of that relationship. And so you can see that the history of intake is no longer associated with that drug-seeking behavior on that initial presentation. And then if we overlay these two, we can see it's a little bit difficult to say with such a small data set, but it does appear that these animals fall on this same regression line, whereas these animals fall apart from that. So we're not putting too much of an emphasis on that, but we have seen evidence of highly variable responses in other experiments. So if you recall the cognitive assays we did, there was a high amount of variability. And also in an alcohol drinking study, what we found was that there was a bimodal distribution in alcohol drinking where half of the animals had significantly greater alcohol drinking than shams, but then the other half fell well within the range. But regardless, the injury seems to disrupt that relationship, at least in these animals. And so what we also did was after those 10 days of saline self-administration, we let the animals start taking the drug again. So this 0.1 dose is what we were training them with. Then we let them So when we let them start taking it again, we introduce the drug in a stepwise fashion and let them take however much they want. So you can see this stepwise increase in total drug intake across these sessions, but it's elevated in the repeated blast injury animals. Now, if you force the statistics with this small data set, it approaches significance. So the main effect and interactions are at p equals 0.07. But unfortunately, our second cohort had to be discarded because of construction, making our sham animals look just like our repeated blast injury animals. So at some point, we hope to garner the funds to repeat this study. But I think based on the effect size that we're seeing here, we're really optimistic that this essentially relapse after a period of abstinence is a really interesting finding. Because if you recall, under this dose, we actually saw an opposite effect where the repeated blast animals were taking less drug under those conditions, but now after a period of abstinence they appear to be taking a greater amount. So we didn't really get into mechanisms at all. We hope to get into that fairly soon. So we did, what I didn't mention is we've repeated this study to that first drug-seeking session. We just finished a study using both structural and functional MRI where animals were imaged within a week of injury and then again imaged after oxycodone self-administration and a drug-seeking session, but our collaborators say it'll take about 6 months to analyze the data. So we've completed the physical experiment, but not the analysis of the actual data. So stay tuned. And specifically what we'll be looking for are correlations between these functional connectivity of the medial prefrontal cortex as well as diffusion tensor imaging metrics of prefrontal cortex and associations with either total drug intake or the drug-seeking behavior. So at this point we can only speculate, but we do know that inflammatory cytokines can modulate neurotransmission. So by changing the expression of transporters located on astrocytes, basal glutamate levels can be altered. Cytokines such as TNF-alpha can actually lead to insertion of AMPA glutamate receptors at the cell surface and also removal of GABA-A receptors. So you can imagine that this would promote increased responsivity of particular neurons to inputs. And then also people have reported hyperexcitability in the intrinsic excitability of cells, meaning that they're easier, they're more responsive to inputs, but they're also more depolarized and firing at a higher rate under basal conditions. So in summary, single blast injury impaired acquisition of learning in a visual discrimination task that required flexible response selection. There's a high degree of variability in the outcome, but we didn't see any effects on the set shift or the reversal of the task. And there wasn't any effects on working memories, and of course, remember the caveats I discussed. Repeated blast injury was associated with a significant increase in oxycodone seeking, and then of course, you know, the caveat of we think that the effect size was large enough for the reacquisition to be significant when we have a chance to replicate this data. And again, we saw that variability in outcome. So future directions, I'd mentioned the study that we completed. We're also interested in pursuing the inflammatory cytokines and the microglial responses that are occurring long-term, especially in conjunction with exposure to opioids, but also testing the effects of environmental enrichment on these phenotypes. So environmental enrichment, so cognitive, social, and physical enrichment, which is thought to mimic several aspects of rehabilitation therapy, has been shown to improve outcomes both in traumatic brain injury and in addiction. So we actually think that this comorbidity would potentially be highly susceptible to this type of intervention. And so I'll end by acknowledging all the people that helped make this possible, the people in my own lab, including former lab members that did a lot of this work, our collaborators for this study, Brian Stemper and Matt Buddy, and then the funding we've had throughout the years to help make this possible.